Rob, or do you want me to record it?
All set, Karthik, recording.
Oh, it is recording. Okay, excellent. All right, so it's my distinct pleasure to welcome Dr. Jason Wollmuth. He's an interventional cardiologist, and he's the director of complex coronary interventions at Providence Heart and Vascular Institute in Portland, Oregon. And we are especially thankful as it's 4:30 a.m. in Portland, and he's been so gracious to give us this talk. And he's going to be talking about large bore access and closure techniques, especially for complex PCI. So thanks, Jason, and go right ahead.
Thanks, Karthik, and thanks, Robert. Thanks for having me. This is a talk I've given several times in the past about access with large bore, specifically related to Impella and challenges that can have both with access, closure, and then delivery of the device. But a lot of the things that I'm going to be talking about today really, also transition over to large bore access for other devices, ECMO, TAVR, et cetera. I'm not a structural operator. I simply do coronary cases, but I think this hopefully will have some benefit for other operators as well as complex operators. So let me see if I can get this to me. There we go. So we're going to talk a little bit about access options for Impella placement or other large bore devices using femoral axillary shockwave facilitated access. And then also I'll talk briefly about transcaval and transcarotid. We'll talk a little bit about single access Impella and some of the things, the advantages that it can give aside from just getting your access for the intervention. We'll talk a little bit about difficult Impella delivery, briefly talk about closure, and specifically spend a little time on crossover dry closure and single access dry closure. And depending on time, we may talk a little bit about complications as well. So, going back and starting at the very beginning with femoral access, I think it's real important to kind of review the anatomy. It's funny, we learn about this when we're fellows, and then we tend to forget about it. And a couple of years ago, I heard a talk from a friend of mine, Dwayne Pinto, who's up near you guys, and learn something new. And so I think it's always good to go back and review femoral anatomy and look at some of the things that we're trying to define, both anatomically, but also to try to define as far as the perfect access site to do femoral access as safely as possible. And the one thing that I learned from Dwayne was that the common femoral artery, we always think about, sticking over the common femoral or over the femoral head, because again, you could push and have the ability to kind of gain control of the artery by compressing up against the femoral head. But it's actually not the femoral head that you're pushing against. It's actually the pubis bone that you're pushing against. We just use the femoral head as an anatomical definition of where the common femoral artery is. And so there's a few things that you need to know about the common femoral artery. One is that this, again, does lie over the pubis bone, but it's really marked by the top and the bottom of the femoral head. The upper part of the common femoral artery is where the inferior epigastric comes out off of the artery underneath the inguinal ligament. And it's important to identify that because that's an area where you want to try to be below the inferior epigastric, because that's where the artery starts to dive deep into the pelvis. So talk about the bifurcation, and it's important to note that usually that's below the femoral head, but occasionally you'll see people with high bifurcations, and that's important when it comes to getting access, particularly with ultrasound guidance. And so some of the things that we're looking for, again, is where does the internal epigastric artery come off, and then where is the bifurcation? And so the way that we typically have defined the anatomy of the femoral artery is the conventional wisdom is the takeoff of the inferior epigastric artery to the area where the vessel then bifurcates into the profunda and SFA. But really functionally, we want to consider that area kind of in between where we're overlying the pubis bone, so we can get good manual compression up against a hard surface to control bleeding if we have any issues. And so this is a lateral diagram of the femoral artery, again, kind of showing the classic definition of where the common femoral artery is. But you can see that, we really want to try to get that area that's sitting just over the top of the pubis bone. And so the advantage of having that over the pubis bone is, again, you can get external compression up against the bony structure of the pubis bone to get good control if there's any bleeding. And so the challenge, obviously, is if you have a high stick, and that's obviously probably the most feared complication or access site, is that you just simply can't get compression of that artery no matter how hard you push. You're just pushing against soft tissue, and you can never get good control of the artery. And so, this is a way I think a lot of us were taught kind of how to do femoral artery access. You put the calipers at the bottom of the femoral head. You then palpate the artery, and then you stick from the bottom of the femoral head, and then just go north at a 45-degree angle. And that works actually fairly well in normal sized thin patients, where you put it at the femoral head and you go in at a 45-degree angle, and you quite frequently will hit it right in the middle of the common femoral artery. But unfortunately, a lot of our patients are not thin anymore, and we deal with a lot of thick patients. And if you use this same technique and go in at a 45-degree angle, oftentimes you're hitting the artery at a very high spot. And so now we've really transitioned to a combo access technique where we use both fluoroscopy and ultrasound to try to identify the proper access site. And so typically what I'll do is identify where I want to enter the artery under fluoroscopy, and then put an ultrasound over that spot, and then adjust my skin nick and entry site depending on the relative depth of the artery and relative size of the patient. So this is kind of how I do it. So I take calipers, I place them kind of right over the mid-femoral head, right where I want to access that site, and then I put my ultrasound probe right over that very spot where I want to enter. And then I'm able to look under ultrasound, in that area where I want to enter the artery. Is there significant calcification? Is there disease where I'm going to be entering? Is there a high bifurcation? Because you can identify the bifurcation on ultrasound. And if so, you can make some subtle adjustments to the access point with ultrasound. And once you've identified that under ultrasound and seen the artery under ultrasound, then we use ultrasound to gain access into the artery. And one of the things that I like to look at on ultrasound is I actually like to see the needle going into the artery. And oftentimes you can actually see the tip of the needle going in the artery. Sometimes you don't actually see the needle tip itself, but you can see it compressing the artery, so you know you're within a few millimeters of that spot where you want to precisely enter the artery. And then after I've entered the artery, and again, this is always done with a micropuncture access needle, then I use a fluoroscopy to watch my wire go in. On the right-hand side here, you can see that the wire is going up the recurrent circumflex artery off of the femoral artery, which obviously you don't want to shove a sheath out there because you can damage that artery. And so I'm looking at, where is my wire going? Is it going in an appropriate direction? And also importantly, where is the tip of my needle? Because that's telling me where my axis is. Is that in a good spot? Is it sitting overlying that pubis bone where I'm going to be able to manually compress that artery if I have any issues? And then once I gain access, I usually use the sheath of the micropuncture kit to do an angiogram. And again, you can identify, if you're near any large plaques, if you're near the bifurcation. It's just a nice way to kind of define exactly where you're at. And then, usually if I can get a good femoral shot with this and there's no evidence of significant disease, oftentimes I'll just go straight in and place my percloses in at that point. Oftentimes, if I'm concerned that there may be disease higher in the iliac system, sometimes I'll put a sheath in and take a picture of the rest of the iliac system. But in a case like this, where you see a very nice, clean femoral artery, the chances of there being significant iliac disease, I think, is less. So I just go ahead and at that point, put in my closure devices and pre-close that artery with 2 perclose devices. I really think it's important to try to pre-close arteries in patients that are getting an Impella supported intervention, and for a number of reasons, but probably the most important is it's in patients that need to have the Impella in for a period of time after the procedure, having that closure device in is probably the only way that I've found to really control an artery if they ooze after you take the Impella sheath out and put the repositioning sheath in. You're able to use that suture to kind of tighten down the arteriotomy, because these Impellas always ooze. Despite what the company tells you, I feel like they ooze every time. And so having that perclose in to be able to tighten down that arteriotomy to prevent oozing is really the only thing that I've ever found that works. And even in a patient who's very sick and in shock and you really need to get the Impella in quickly, I think taking that extra minute to put a perclose in can really be a significant advantage, because again, bleeding can be such a problematic issue in these patients that need to have the Impella in for a bit of time. So I place both percloses in, and again, like most people probably have been taught, we tend to put these in at 10 o'clock and 2 o'clock. I don't know how dogmatic we need to be about that, but that's typically what we do. And we want to make sure we get good closure with both of those. And then after I put the perclose in, I usually tape them off to the sides with a tegaderm just to kind of keep them out of the way. And then at that point, you can dilate up the artery with the arteriotomy devices or the dilators if you need to. Although now with the long graduated dilator, I usually just go in straight with my Impella sheath, and then you're able to deliver it. I think you can use either the long or the short Impella sheath. I tend to use the long one more often than the short one, but again, it's just personal preference. And so there are a couple of mistakes that we see in people, particularly younger operators who are learning femoral. We become so good at radial first that oftentimes we just don't have the experience that we have with femoral access. And so a couple kind of common mistakes that we see. One is not using both a combination of fluoroscopy and ultrasound. Number two is oftentimes you'll see people find the femoral bifurcation by ultrasound and then scan up and hit the artery up above that. And most of the time that will work, but occasionally if you have that patient that has a high bifurcation, all of a sudden you're sticking in the pelvis and really getting a high stick. Oftentimes people will fix it on sticking the common femoral artery without really a regard of the location over the femoral head and the bony structures. And then the last one that we see occasionally, and this can become a big issue, particularly in patients that are a little bit bigger and have a larger pannus, is people kind of are staring at the ultrasound screen and they're taking their needle and they're kind of moving it all over, kind of looking to find it. And they kind of have this like Z-line tracking through the subcutaneous tissue. And that can be a real challenge, because if you get in and you get a wire across that, all of a sudden when you try to put in a dilator, it folds up in that in the fat underneath the skin and can create a lot of damage to the artery. And so typically what we'll try to do is we'll go in at a straight line with the needle. If we don't hit the artery, we pull it all the way back and then redirect. And so you're not kind of weaving your way through the subcutaneous tissue. And then the last is going in with a real steep or inappropriate access angle. Obviously, you don't want to go real shallow and then end up with a high stick, but you also don't want to go in at a real steep angle, because oftentimes those are the ones where you can get kinking of your Impella sheath. And so, as far as the size of the artery, obviously we'll take a quick picture with an angiogram to kind of get a general sense of the size. But generally, if the artery's over 6 millimeters, patients usually don't have any issues at all. And if the artery is less than 5.5, usually the risk of there being vascular complications starts to increase significantly. And for every millimeter of decrease in vessel size, there's a significant 35% increase in risk of vascular complications. And so in patients, when we do our first initial picture with our micropuncture kit, what I'll do is I'll get a general sense of the size. And if it is looking a little on the small side, oftentimes at that point, I immediately go in and put a wire in antegrade before I put the Impella in, just to make sure that I've got easy access to put in an antegrade perfusion sheath on the ipsilateral limb. And it's a lot easier to gain antegrade access when the Impella is not in the way. And so what I'll oftentimes do, and I've kind of gone to doing this over the last few years, is I'll get access with my micropuncture, put my micropuncture sheath in. If the artery looks small, I take the micropuncture needle and immediately stick antegrade, and then put the micropuncture wire into the SFA antegrade, and I just let it sit outside the body, hanging outside the body for the rest of the case. And that way, once I'm done with the procedure, if I need to leave the Impella in and there's poor flow down the leg, then I've already got my wire just sitting in there, and then I just slide a slender sheath over it to antegrade, and it's real quick to gain access to have that bypass for the leg. And we'll talk a little bit about how to put a bypass in a little bit. So we do kind of have a high-risk PCI algorithm that we follow at our institution, but one part of the algorithm that we have is looking at access options. And so in patients who have relatively small arteries, who have significant iliofemoral tortuosity, patients who are morbidly obese oftentimes have a higher incidence of bleeding and oozing around the sheath, particularly if it needs to stay in, or patients who are going to need to have prolonged support. If any of those things are notable in the patient, then those are the patients that we would oftentimes consider an alternative access. We don't do transcaval access at our institution. We primarily do axillary access for our alternative access. We've also talked about doing carotid access, but we haven't done it yet, and I'll talk about that in a little bit. But in these cases where we think it's going to stay in, or they have some issues in their femoral or iliac system, those are the ones that we'll typically consider going axillary. And so for axillary access, this oftentimes has a lot of fear for people that are new to large bore access. Sticking into somebody's or near somebody's chest is sometimes a bit intimidating. And so I learned how to do this probably about 4 or 5 years ago, and I actually did my first few cases with one of my cardiac surgeons who's actually vascular surgery trained as well. And so it's really a good way to learn by somebody who has experience in this area. But when we're getting axillary access, we're trying to get to access into an area of the artery that obviously is a good caliber, free of side branches, but also free of other surrounding structures. And the axillary artery is typically divided into kind of 3 segments. And you can see on the left-hand screen, there's kind of the first segment, which is right near the chest wall, the second segment, which kind of sits in that space between the glenoid cavity and the chest wall, and then the third space where it's really starting to go out towards the arm. And most of operators that do this try to gain access into this second area. I actually tend to favor getting a little closer towards the first area, maybe not in the first area, but kind of close to it, because if you are a little bit closer, you're right near that second rib, and so you can actually use it to compress against the second rib if you have any oozing. And so it's important to kind of have a sense of this because the brachial plexus, which is obviously probably the biggest fear of getting axillary access, is really free of the anterior aspect of the vessel in the second portion of the vessel. And so we typically try to avoid going more distally as well in the third portion, because then you're starting to get down into the medial brachial fascia compartment, which if you have bleeding down there, you can potentially increase the risk of compartment syndrome. And so you really want to try to hit the second portion, or the right near the border of the first and second portion of the vessel. The typical diameter of an axillary artery is around 6 millimeters, and it's fairly uncommon that you'll find that somebody has significant disease in this area. In patients that do have significant iliofemoral disease, they have a much lower incidence of having axillary disease, and so this is oftentimes very safe. And for unknown reasons to me, they tend to be free of significant atherosclerotic disease. And so when we're starting to get access into the axillary artery, we usually gain access either through the radial artery or the femoral artery to do angiography. I actually prefer going radial for a number of reasons, but one is it's I think it's a little bit safer. Two, you're going axillary for a reason, and oftentimes that means they have a lot of iliofemoral disease anyway. But I also like to have my radial sheath in, because that way, if the axillary sheath is occlusive, I've got access into the distal vessel, so I can put a bypass to that arm real quickly. And so what we'll do is we'll gain access, again, either radial or femorally, and then do an angiogram of the axillary artery to kind of assess for side branches, disease in the vessel, et cetera. The other thing we look for, and one reason why I like to go axillary as well, is I'll drop a wire all the way down into the ascending aorta. And if you've got a really steep aortosubclavian angle where it's really retroflexed over 90 degrees, those sometimes can be difficult to deliver an Impella around. So those are cases where I would consider switching over to a left-sided axillary access. And then what we'll do is we'll place a wire across the axillary artery. So then we use that as a way to identify the artery under fluoroscopy. And so I use fluoroscopy to identify the entry point, and then I put the ultrasound right over the spot where I want to enter the artery. And the nice thing is if you have the wire in there, you can actually see the wire under ultrasound. So it really helps you identify exactly where the artery is. And then we use micropuncture access. We visualize the artery and the needle entering the artery, and then we pass the micropuncture wire. And again, do that under fluoroscopy before removing the needle, so we can precisely identify exactly where our needle went into the artery. Again, here you can see a still frame of a ultrasound image that shows kind of the artery or the wire in the artery. Sometimes you can even move the wire a little bit just to make sure it's not a chunk of calcium, but you'll see it move. And then again, we use ultrasound to kind of identify exactly, or excuse me, fluoroscopy to identify exactly where we're going into the artery. The one thing that's a little bit different about axillary access as opposed to femoral access is you want to make sure you're going in with a little bit shallower angle. Normally you go in at about a 45 degrees for the femoral artery, but for the axillary artery, you tend to go a little bit shallower, like 30, 35 degrees. And the reason is that the way the artery kind of turns up as it's going into the chest is oftentimes you'll end up with this kink in the sheath of the Impella, which you can kind of see here. This is an access where I was a little bit probably too lateral and probably went in a little too steep, and then ended up with a sheath that kinked. And so after access is obtained, oftentimes, again, if there's any concern about side branches, you can do an angiogram through your micropuncture sheath. We'll then dilate the arteriotomy and then put the 2 percloses in. I still use 2 percloses for axillary as well. And then you can either use the 10 and 12 French dilators to dilate it up, or just use the single graduated dilator that they now have with the sheath. And then you'll deliver the Impella sheath in. The other thing that you want to note is you don't want to take the tip of the Impella sheath around any tight bends. And so oftentimes we'll leave this kind of sitting in an area before the artery starts to make the turn down into the aorta. And with that, you'll oftentimes have a few centimeters of the sheath sitting outside the body. And obviously with axillary access, we'll use the short Impella sheath, not the long Impella sheath. So we've also gone to using Shockwave facilitated femoral access, and this has become kind of our backup if axillary isn't as good of an option. This is actually a 78-year-old gal who was referred for complex left main bifurcation and RCA CTO, was turned down surgically, has known left subclavian occlusion and an occluded right carotid artery. She had an ultrasound of her right brachiocephalic that had evidence of a high-grade stenosis. She had non-palpable femoral artery pulses, and the diagnostic cath done at an outside institution was done through the left common femoral artery. But before she was transferred up, they ended up getting a CTA, and they found that the right common iliac stent that had been put in several years prior was occluded. She also was noted to have a left common femoral artery occlusion with calcific moderate disease throughout the iliac system on the left. So this was a case where we really had kind of poor options. Both axillary options weren't great. The right wasn't really an option unless we opened the common iliac artery. We also actually discussed going potentially transcarotid in this case. At our institution, we do a lot of transcarotid TAVRs, and one of my surgical colleagues and I have been talking for years about doing a transcarotid high-risk PCI, but we've never found a case because we've always been able to find another way in. And so we decided, actually had discussion with one of my vascular surgeons. We decided to see if we could go in left common on this lady, and I'll show you how we do that and how we did that in this particular case in just a bit. This is really a good option in patients who don't have good axillary options and have disease in the iliofemoral system. If there's calcific disease, oftentimes you get dissection or inadequate expansion with PTA alone. Obviously, if you put stents in, then sometimes you're trying to pass the Impella through the stent, which has a risk of getting trapped in, or grabbing it with the cage and the inflow and the outflow of the Impella. So we really try to avoid stenting if we can. But Shockwave really gives us the advantage that it kind of creates these cracks in the calcium and kind of gives that artery some elasticity and some ability to expand because of the fissures that are created in the calcium. We've all seen this in the coronaries, and now with our experience with Shockwave, how it creates these kind of cracks and fissures in the calcium. And same thing happens in the iliac, and it basically gives that artery some elasticity to be able to expand to advance the sheath. There's a study a couple of years ago from Carlo DiMario that looked at the use in TAVR patients and really showed that this was highly successful and very, very safe, leading to very little vessel injury. So this was the case where that gal had really limited options. So we were able to gain access into the common femoral artery, and we actually kind of gained access a little bit high. I actually had one of my vascular surgeons there with me because we were thinking that if this didn't work, we were going to have to cut down on the artery, do an endarterectomy, and then gain access through that. But we were able to actually gain access kind of just at the upper end of the femoral head there. And then we did an angiogram. You can see the artery's quite small, but we were able to actually get into the artery. We actually did a 7x60 Shockwave, and then we were able to deliver the Impella actually relatively easily with the long sheath, and then did the rest of the case with single access. And then when we were done, we did a completion angiogram with what we call single access dry closure. And I'll talk more about that in a little bit, but we're able to get this case done successfully through single access. I'll just jump through this. This is just another case of Shockwave facilitated delivery of an Impella sheath. The thing that's kind of interesting is you'll Shockwave these, and the artery doesn't oftentimes look a whole lot different than it did when you started. But again, it just creates those cracks and fissures and allows that artery to have some ability to expand. Like I said earlier, we don't do transcaval, but I think it's really important to know that this is an available option for patients with access challenges. I think it's important to know and know, local institutions potentially, or institutions in your area that may have this option in those rare cases where you may need it. Like I said, our institution, our preferred alternative access for TAVR is transcarotid. I think our group has the largest experience of transcarotid in the world. They recently published their series on it. And again, it's an option potentially for high-risk PCI. But there are several issues with these. One is it's obviously dependent on operator and local skill set. There's a challenge with implementing it quickly in a patient who's unstable or in shock. And then these are also issues where, if you need more prolonged support, these can be challenging if sitting in a carotid artery or sitting across the cable, because those are the patients that would need to be lying flat. And so, we always think about these options, but I think these are very rarely needed now with good axillary access and facilitated femoral access with Shockwave. We're going to talk briefly about single access. This is kind of a technique that we have been using now for several years to allow placement of the PCI sheath through the sheath of the Impella for single access for high-risk PCI. I did my first case on this, I think it's about 3 years ago now, and ended up putting it on Twitter, and it kind of went viral a little bit, and now it's become a common way to do high-risk PCI. We actually published our first 17 cases back in October of 2019. And since that time, the most recent data I saw that over half of Impella-supported PCIs are done with single access. But basically, you just get your Impella sheath in like you normally would, and then we gain access through the diaphragm of the Impella sheath. You can use an 18-gauge access needle. I usually just use the micropuncture needle that I've used to gain my initial access. And then the thing that you want to make sure is like the diaphragm has some preformed slits in it. Obviously, they have the slit that's more vertical that allows for the sheath to be peeled away. But you want to try to avoid that, because if you get too close to it, you can get some oozing through the sheath. So I usually kind of gain access right around 2 o'clock, as I showed right there. And then simply this just allows for placement of the 035 wire. Here's a video of me gaining access. So this is an axillary case. You can see we just use a micropuncture needle, drop a wire in. This again is just the micropuncture wire, and then I just use a stiff micropuncture for most of my access, and then you just place that in, and then again that allows you to get the 035 wire in. One of the things is on the you want to kind of be about halfway from the kind of orange rim of the Impella sheath to the shaft of the Impella. And inside the diaphragm, there's a little ridge, and occasionally it'll hit that and you'll feel that. So if I hit it with the needle, I usually try to go a little bit closer towards the shaft of the Impella. And then once you've got your 035 wire in, then you can place your PCI sheath. Sometimes there'll be a little bit of resistance going in. One of the things you'll notice that I'm not doing here is I'm not holding the shaft of the Impella, which is an important thing, because you don't want to push your sheath in and then accidentally push the Impella in further as well. And I'll show you a case of something that went wrong at another institution. And so options for sheath sizes, you can use a 6 or 7 French. The 6 French sheaths work well because you don't have really any interaction with the Impella. The 7 French sheaths work well as well, but there are certain 7 French sheaths that don't work. And it's important to know that 8 French sheaths don't fit. You can't put a sheath in with the Impella 2.5 sheath, but you can do single access with the 2.5 sheath to put a wire in or balloon in, which can be useful for other issues, which I'll show in a little bit. But it's not big enough to incorporate another sheath for PCI. So as far as the sheath options, the one that I typically use is the Pinnacle Destination 45 centimeter sheath, because it has an extended hydrophilic coating on it. So you're able to deliver it almost all the way into the vessel. There's still a portion of it that will stick out. And that can be an issue in patients that are taller, because sometimes you won't have enough be able to get enough guide in to reach the coronaries. But in most patients, it works just fine. In people that are taller, I will typically use a Merit slender sheath. There's 2 different slender sheaths. There's the Merit slender and then the Terumo slender. The Merit slender is braided and has a lot more radial strength than the Terumo slender, so I like to use that one if possible. The Bright Tips, Cooks, Rabbies, and the regular Terumo slender haven't worked for me. The Cook and the Rabbi just are not hydrophilic, have enough hydrophilic coating, so you just can't get it in far enough. I like to go with the longer sheath, because then you have less interaction with the shaft of the Impella. Sheathless guides have been described. I'm not exactly sure why you would necessarily do this if you were using 6 or 7 French, because you can get a sheath in anyway. But 8 French guides have been tried 3 times that I know of, and 2 of the 3 didn't work. OCAS should be able to be used. I know the 7.5 has been used successfully, and the 8.5 has not been described that I know of yet, but theoretically it should fit. as far as complications, there's really minimal complications. You can get some bleeding from the diaphragm. If you get this, you just need to re-access it. If you get, one of my partners had one case where he had some bleeding around the sheath, and we think it just kind of altered the sheath enough that there was some oozing. We just tightened the perclose sutures and that stopped it. I've heard of one case where the sheath was actually torn, and so they had to actually take the sheath out and put the repositioning sheath in. There's lack of second access to potentially manage a complication. And then the last thing, which I mentioned earlier, is that while you're advancing the sheath, if you don't fix the shaft of the Impella, you can actually push the Impella forward. And this was an unfortunate case where an Impella was actually pushed out of the ventricle and created a hole, and the patient had to go to emergent surgery, which obviously you can imagine was not did not turn out well. The other reason, though, that I'll use single access is for difficult delivery of the Impella into tortuous anatomy. And so here you can see a case where the guy has had a lot of work done, has a lot of tortuosity, has an aneurysm in the iliac artery. We're able to deliver the long Impella sheath relatively easily. But then when we tried to deliver the Impella, we just simply weren't able to get it through, and you can see that our Impella sheath kinked. And so the best way to deal with a kinked sheath is actually, as you're holding forward pressure with the Impella, just kind of pull back on the sheath a little bit, and it will move that kink, and oftentimes you're able to pop the outflow cannula past that area. It's always the outflow cannula that seems to get stuck on things. Here's a case where we're not able to deliver the Impella around some tortuosity going in from the iliac into the aorta. So what we did is we used single access to place a Lunderquist wire to kind of straighten out that whole system, and it was able to straighten it out enough that we were able to, let me see if I can go forward here. We were able to get it past. Here's another case. Again, I think actually this is a case where we were able to get the Lunderquist wire past the Impella, was just getting caught in the distal aorta, just kind of straightens things out enough that we were able to try to deliver over it, but it still wasn't able to go. And so we ended up passing a balloon over the wire, again, all done single access, inflated the balloon, and as we deflated the balloon, we were able to advance the Impella by. So again, it's a way to get additional gear in when you're having difficulty delivering an Impella. There's a case where we had to do a BAV to get an Impella in. You know, generally when I have to do this, I try to avoid this if at all possible, but I tend to use smaller BAV balloons because you just don't want to create a lot of damage to the aortic valve and develop AI, because then you're losing the advantage of having the Impella if all the blood's leaking right back into the ventricle. And so this was a case where we did a BAV. I think I started with a 20 true balloon. Did the BAV, had some difficulty getting even a 5-French diagnostic catheter through the valve. It was really calcified and really tight. Did the BAV, but we weren't able to cross after an 18. I think we did an 18 and a 20, and we still couldn't get the Impella across. And so, you know, one is you could go with a bigger balloon, but I was, again, worried about creating too much damage to the aortic valve. And so what we decided to do is gain second access through the Impella sheath, again, using single access technique. And we were able to deliver a second wire across the aorta. And then we used a 14x40 peripheral balloon and did several balloon inflations. And then we basically did like a modified balloon assisted tracking. So we inflate the balloon, and then with the balloon inflated, it was able to just kind of hold that valve open enough that we were able to then deliver the Impella through the valve. So again, just another kind of creative way of using a single access for kind of overcoming challenges with difficult Impella delivery. As far as closure goes, you know, there's really kind of two devices that are used in the US, primarily the Perclose family of devices, the ProGlide and now the ProStar, and then Manta. We made the decision a few years ago, after kind of consulting with friends and colleagues who had used Manta, to not bring it in. We actually do have it now, but it's just sitting on the shelf gathering dust. we've become pretty good with the ProGlide, ProStyle, and having really good success with closure with these. Oftentimes, if you don't get great closure with a couple per closes, adding an angioseal to finish the closure oftentimes is all that's needed. And so we just haven't really found a use for MANTA in our lab. I'd certainly be curious to know what your guys' practice is. But I think, it's one of those things that if you get good at it, it may be a reasonable option for some patients. One of the things that we will do occasionally is do dry closure. And so dry closure was originally described using a contralateral technique. You can also use a radial or a technique with some of the longer balloons now that they have for radial to femoral intervention. And so but typically what we'll do is we'll gain access to the contralateral femorally, and usually we'll try to at least use a 7 French, because on those rare cases where you need to deliver a covered stent, most oftentimes you need to have a 7 French. And so we'll take a catheter. Usually I'll use an OmniFlush, but you can use an IM or a RIM catheter to get up and over the aortic iliac bifurcation to place an 035 wire down into the ipsilateral iliac that you're trying to close. And then you'll deliver a long braided sheath up and over into the ipsilateral iliac. And then you take a balloon and you position it in the external iliac artery and inflate it at 2 to 4 atmospheres, just enough to occlude the vessel, but not cause any trauma to the vessel. And we generally try to size the balloons kind of 1-to-1 to the size of the vessel. At that point, once the balloon is inflated, we remove the Impella sheath, and then we tighten the per-close sutures. At that point, we deflate the balloon and assess for bleeding. If we don't have much bleeding, you can either do an angiogram through the sheath that you have in place, or you can actually remove the wire from the balloon and use the wire port to do an angiogram to assess for any bleeding. If there is a decent amount of bleeding, you've still got your antegrade access with a wire. You can add another closure devices if needed. Worst case scenario, if you have severe bleeding, you can always advance your balloon down and balloon tamponade the bleeding. But most of the time you get reasonable closure with your initial closure that you don't need to do that. But occasionally we'll need to add a second device. But it's just a nice way to avoid a lot of bleeding, particularly in patients who have a lot of challenging anatomy or atherosclerotic disease in their common femoral that you're worried about the adequacy of the closure. So as far as axillary access, generally we'll do it fairly similar. The one difference is I usually will pass an 018 wire into the distal brachial artery, and then over that pass an 1-to-1 to the vessel, remove the sheath, and deploy the per-close sutures. And then with that 018 wire, and you're still able to inject through the wire port. So we'll inject through the wire port and look for any bleeding. And if there is any bleeding, this is one where I tend to do a lot more balloon tamponade. So I'll put the balloon up at nominal atmospheres over the arteriotomy, and then hold external manual pressure. And usually 5 minutes is all that it takes, and it almost always completely seals these. There's always the option, though, if you've done per close, if you've got wire access, you can add another closure device, the angioseal, another per close if needed. But it's really rare nowadays that we need to use a covered stent. I don't think I've put an axillary covered stent in for probably 3 years now, just by better technique and some of these options of doing balloon tamponade to control bleeding. The other thing that we've done a few times is in patients who have single access, one of the criticisms is you don't have another access to control bleeding or to do contralateral dry closure. And so this is something I learned from Raj Tayal in New Jersey, was how to do single access dry closure, and actually wrote this up with Raj and Hade Lichi, where you basically through the Impella sheath, you place a balloon in the external iliac artery, and again, inflate it to a nominal pressure, and then remove the Impella sheath. And then you pull the perclose knot down onto the arteriotomy, but you don't push it and tighten it or lock it. But you just pull it down to the arteriotomy, and then you kind of assess for bleeding. And if you don't have a whole lot of bleeding at that point, you deflate the balloon, again, recheck and see how much bleeding there is. If there's not significant bleeding, you can inject through the wire port of the balloon and assess if there's any evidence of extravasation. If there's minimal bleeding at that point, usually we'll just pull out the balloon, tighten the perclose sutures, and cut them. If there is ongoing bleeding, then you can remove the balloon and deploy an additional closure device if necessary. I will do this on occasion if I'm really concerned about the adequacy of closure in single access, and certainly in patients who have limited access options. It's something that I think is real important as a way to kind of do this in a safe manner and kind of give you a little bit of protection for bleeding if you're having issues. We talked a little bit about kind of, if you have occlusion of the vessel with your Impella, how to get antegrade access with a micropuncture needle and wire to create an external bypass. And so this is something that I think is very, very important, and I don't think is done very often. But in our lab, it's kind of become mandatory that if the patient leaves the lab with an Impella, they have to have an angiogram before they leave, because we've had too many cases where the patient gets downstairs and an hour or two later you're getting calls from their nurses because their leg's cold and they can't Doppler any pulses, and then at that point you're kind of scrambling. And so the nice thing is with the repositioning sheath with Impella now, they have that wire port, which is helpful for doing closure after these need to come out. But we use that to do an angiogram through the sheath to assess for flow in the vessel. And so everybody that leaves the lab with an Impella gets an angiogram through the wire port of the Impella repositioning sheath before they leave. And so if you have a case where you do that and they do not have good flow down the leg, it's much easier to deal with it while they're still in the lab. We'll gain retrograde access usually on the other femoral. You can use an arm if you need to. And then at that point, we gain antegrade access with the micropuncture wire and needle on the ipsilateral side. Again, here you can see that we're getting into the SFA. One of the things you'll notice is my stick is very low in the SFA here. And it's not over the femoral head. And again, if you've already done this with the Impella in, it's hard to gain access into the common femoral. Whereas if you do it before the Impella goes in and you just leave a wire there, it can be really, really helpful and save a lot of trouble getting access around this Impella sheath and having a low stick, which comes with some risk itself. After we get access, we put the micropuncture sheath in, and then we'll do an angiogram through that just to make sure where we want to be. In this case, this was a patient who had an occluded SFA, and so we had to gain access into the profunda, and then we were able to deliver a braided sheath into the profunda to create a bypass. And so to create the bypass, you simply join the side arms of the two sheaths with a male-to-male connector. Obviously, you need to de-air it, flush it, and then hook it up. And usually we'll go 5 and 5 or 6 and 6 as far as the sheath size. Because the Impella is occlusive, the antegrade sheath is actually a lower pressure system. And so with that, you get good flow from the higher pressure retrograde sheath into the antegrade sheath. And then this also can be done for the axillary access. And so frequently when I do axillary access now and I put my Impella sheath in, I'll have access into that radial artery. So the first thing I do is I hook up the radial artery sheath to pressure and just check and see what my pressure is and how my waveform looks. And if I have a really low pressure or no waveform, then I just hook the sheath of the Impella sheath sidearm to the sidearm of the radial sheath with a connector tubing and a male-to-male connector. And this is important when you're doing axillary access, even if you're going to get it out at the end of the case, because patients get really antsy when they're on ischemic for an hour or two. When you're trying to do their PCI, they start getting really antsy. I figured this out the first time it happened to me. Just the patient was just squirming the whole time, and as soon as I figured it out and hooked up a sheath and got some flow there, they just stopped moving. They oftentimes don't even verbalize it; they just start getting really antsy. So we'll do that oftentimes in these patients where the Impella is going to be occlusive, and it's obviously critically important in patients who are ill and are going to need the Impella in for a period of time. So I do have some complications, but I know we're kind of pushing the hour, so I think I'll stop at this point and open it up for questions.
That was a wonderful talk, Jason. Anybody have any questions? So I'll just start off with one. So Jason, you mentioned a lot about the bleeding issues and how to manage and such. What's your experience been with thrombotic complications and with your axillary access, especially?
We've the ones that need to stay in for a long period of time. We've had a couple cases where we've ended up with some thrombus in the arm, but we've never had an issue where we needed to do much for that, do thrombectomy or anything like that. Most of the time, they're just laminar thrombus, and oftentimes we'll just do some ballooning and make sure we've got flow, and then they usually resolve on their own. The arm actually is pretty good at tolerating ischemia and creating getting blood to the arm, even if you are occlusive. And so it hasn't been an issue. But the challenge with these cases is if you do have occlusion of the artery and you create a bypass, usually it's going into a radial sheath. There's an area of dead space in the upper arm that's not getting normal flow. And so although you prevent hand ischemia, you need to understand that there's probably going to be thrombus there. These are the cases that we tend to favor having our surgeons do an axillary cut down. Even if we're just going to be using a CP for support, they don't need a 5.0 or 5.5. But if they do a cut down and put a chimney off the axillary artery, you just don't have those bleeding issues like you do if you go with a direct stick. And so those are the cases now that, if we think it's going to be in more than 24 to 48 hours, we usually have our surgeons cut down.
Jason, it's Rob Adaran. I was wondering if you've tried the new, slightly improved version of the ProGlide, the Pro Style catheter, and whether what your thoughts are on it.
Yeah, we got it, I don't know, 3 months ago or 2 or 3 months ago, and I've used it a handful of times. I think I like it better. I think it does. We have fewer cases where we don't get capture of the suture. The times where I've found that it's really helpful is when you're getting access through heavily scarred tissue. I did a case very early on with when we first got Pro Style in. It was a femoral Impella case where I was going through an artery that had an endarterectomy. And so you know how those can be just so hard to get in. They're just incredibly tough and scarred. And we were able to gain access pretty easily. But I think I tried 3 percloses, the ProGlides, and all of them failed. And then put in 2 Pro Styles, and they both captured. And so I was kind of a convert at that point. So in patients, they're a little bit more expensive. I don't think that's much of a difference, but they are a little bit more expensive. But we still have both of the devices. And so, if it's a typical normal person that doesn't have much disease in the artery, I think you can use either one. But anybody that has any calcification or disease or has any scarring, has tough fibrotic tissue, those are the ones where I've found that it has its advantage, and we seem to have less failures. So I kind of like it. What's your experience, Rob?
Yeah, we've not tried it yet.
Yeah.
So yeah, but yes, I do understand that the needles are supposed to be a little bit better at penetrating, and I think the hydrophilic coating has been extended throughout the length of the device.
Yeah, they made a couple other minor modifications, like the area where the wire repositioning, or the area where you put the wire back in. They kind of have it marked a little bit better, and they have a depth finder and some of these other things, which, I think it's more gimmicky, but it's really the sutures that seem to capture quite a bit easier. So that's been our experience with it. I still have both of them, and like I said, in probably the majority of cases, it probably doesn't make a big difference, but those ones where it's really hard and calcified or fibrotic or hard tissue, they tend to work a little bit better, and they're expensive enough that you have a couple failures, it's that's, I don't know, $900 if you fail with two of them. And so if you can avoid that, it's certainly worth the cost of it being, I think it's $20 more for us.
So Jason, you mentioned the single access, technique with Impella. Obviously, that's been revolutionary. But is there any? Has anybody used that to connect to the antegrade perfusion sheath, or is that not something that works? So in cases of vascular, compromise in the leg.
Yeah.
You're leaving it in or something.
Yeah, you can do that. Obviously you need to get your antegrade access, but you need to leave the Impella sheath in. And so, because you can use the sidearm of the Impella sheath to connect to your antegrade perfusion sheath. So it's basically ipsilateral retrograde antegrade. And so it's one of those things that we always debate. Like, we're in there, we know the Impella sheath's occlusive, but if we take out the Impella sheath, is it still going to be occlusive? And you don't know. But you pull it out and you rip the sheath. If it's still occlusive, it's still occlusive. I have tried to hook the wire repositioning port from the wire port from the repositioning sheath to an antegrade perfusion sheath to see if it worked, and it doesn't really work reliably. And the reason is because usually that area where the inflow is actually occlusive as well, and so you're just not getting enough flow through it. I have tried it; it just doesn't work very often. And you'll notice this a lot of times, like when you go to take a picture through the wire port before the patient leaves. If it's occlusive, oftentimes it doesn't even bleed back, and so then you're occlusive. And so oftentimes when you need it, that it just doesn't have enough flow to it to work. So yeah, we always debate about, should we leave the Impella sheath in, and in general, at that point I get a ton of pushback because the nursing staff in our ICU kind of has this hard stop when somebody comes down with the Impella sheath in without the repositioning sheath in. They freak out because they're worried they're going to tear or rip or bleed. I know there are other institutions. I think Amir Kaki has done this quite a bit, where he sent people to the unit for shorter periods of time with the sheath in, and they do just fine. But in our institution, our nursing staff, I mean, they've written some of my colleagues up for trying to get away with it. They freak out. So
when you have these perfusion sheaths and ischemia issues going on, do you use similar anticoagulation?
Yeah, we'll generally use similar anticoagulation. These are people though that you just really need to kind of be very vigilant about. it's not uncommon that you do have some thrombus because there's oftentimes a space between the Impella sheath and then the antegrade perfusion sheath. There's usually a dead space in there. And when these come out, there's almost always thrombus there. And so you just know that you need to know how to manage that. And these are oftentimes cases too where I'll have our vascular surgery team get involved early and follow these people with us, just in case we run into those issues and need some help, managing it when things come out. And again, I think, one of the keys too is trying to think ahead and trying to avoid complications. So getting surgical colleagues or other colleagues involved that can help you manage these things long term, but also kind of thinking ahead before they go in. Obviously, somebody's crashing and burning, you don't have a whole lot of time to think about what's going to be your best access. But if it's somebody that you do have a bit of time in and you think they're going to need the Impella in for quite a while, these are the ones where we really like to have our surgeons do a cut down and just put a chimney on, and it makes it so much easier to deal with. They can close those at the bedside. They don't even need to go back to the operating room to close them now. And so they're just a lot safer, and we'll run into a lot less issues with thrombus and bleeding and things like that. So, we fairly frequently will call our surgical colleagues and have a low threshold to do a surgical cut down if we think it's going to be in for, if it's going to be in more than 2 or 3 days, we really want to try to avoid, percutaneous approach for those.
Jason, it's John Forrest. I really enjoyed the talk. I apologize, I missed the beginning of it. The other thing that we've found incredibly helpful that people don't have a tendency to do is, one, to look back at the prior angiogram. Some people have them, some people don't, but almost everybody who comes into our hospital has a prior CT of some sort.
Yeah.
And a lot of times it's an abdominal or lower extremity. And you look at those CT scans, you honestly, your ultrasound's helpful, obviously, for where you want to be, as you've shown, and sure, an angiogram's nice, but you can learn so much from the CT scan before you even decide where to go with your micropuncture, et cetera. And so in these patients, we've really encouraged our fellows, look back, see if they've had a CT scan, and you can figure out where you want to puncture, where you're going to get into problems before you've even prepped and draped the patient.
Absolutely. Yeah, I totally agree. And, it seems like more and more patients have a nice CT femoral angiogram because they're going to be getting their TAVR too. And so, it just makes your planning so much easier. I mean, even just looking at things like tortuosity, but looking at, degree of calcification, even if it's a non-contrast, and so you don't know if there's stenosis, if you see a bunch of calcium up and down it, you're going to potentially run into problems. So I totally agree. Just doing a little bit of a quick chart dig and seeing if there's an old scan can really kind of help you save a lot of time.
Awesome. Great. Well, thanks, Jason, again. That was a tremendous talk. I certainly learned a lot. And we hope to welcome you, someday in person.
Yeah, well, hopefully, it seems like relatively soon we'll get back to doing more in person, right?
All right. Thank you.
Much.
And all the best for your trip.
Yeah, you bet.